guys in St. Thomas's Hospital. This is the London Bridge, the Tower Bridge here, River Thames here. This is the Shard. It's not as tall as, is it Medic 118? What's your tallest building here? Yeah, so it's not there yet, but we're very proud of this building. Yeah. So, laryngeal framework surgery, Ishiki type 1, 2, 3, and 4. We've got this technique just because of the full efforts by Professor Ishiki. This book, you can still get it on eBay. I don't think it's in production. I was opportune to meet Professor Ishiki. He came to my course in Manchester in 2015, and I went back to Kyoto to visit him, and I interviewed him about the reason why, well, how did he come about developing Ishiki pharoplasty, and I've published this on ENT and Audiology News, so you can read the full article there anytime. But essentially, he didn't set off to be a doctor. You know, the Japanese, they respect their parents so much, and his dad wanted him to do medicine, and he wanted to do physics. So until when he came across an article by Van der Berg in Holland about the mechanics of the larynx. So Van der Berg is not medicine, he's not a doctor, he's just a physicist, and he described how the vocal cord moves. So Ishiki went over to Holland and did some kind of fellowship with a physicist, and this is how comes he developed Ishiki pharoplasty. And this is the video, this is the interview with him. You can hear his voice in the background.
What about type 3? Type 3 is rather unusual mutation, but mutational voice disorder may last a long time. Then there's an indication people the patient.
As you know, Ishiki sadly passed away in 2022 in Kyoto at the age of 96. And this was the video that Ishiki made with Van der Berg in the 1970s. So you can see it's a black and white video. And if you understand this video, you'll understand the principles of type 1, type 2, type 3, type 4, which we're going to be discussing. And I hope with time we'll be able to show you in the cadaver dissection tomorrow. This is Ishiki with the Van der Berg.
Here are the muscles that move the arytenoids in various ways. The posterior cricoarytenoid muscles are these large ones which cover much of the cricoid plate. They are called posterior because they are at the back, and they are called cricoarytenoid because they arise from the cricoid and are inserted in the arytenoids. With attached threads, we can simulate the action of these muscles. We shall do the same with all the others as well. When the posterior cricoarytenoid muscles contract, they separate the arytenoids with a complex movement, largely rocking. Joining the arytenoid cartilages at the back are 3 interarytenoid muscles. On the surface are 2 small, inconspicuous muscles crossing each other to make a letter X. They are called the oblique arytenoid muscles. Beneath them, running from side to side, is a larger, much more powerful muscle called the transverse arytenoid muscle. When these muscles contract, they draw the arytenoids together. The lateral cricoarytenoid muscles can now be seen. They are called lateral because they are at the sides, and cricoarytenoid because they arise from the cricoid here and extend along the upper edge of this cartilage to be inserted in the arytenoids. Notice that these muscles attach to the muscular processes of the arytenoid cartilages. When the lateral cricoarytenoid muscles contract, the muscular processes are drawn forward. This results in an interesting adjustment of the vocal processes, which we shall see better in another position. We shall look down on these parts in much the same direction as they are seen in a laryngeal mirror. We observe the movements of the arytenoids as each pair of muscles contracts and exerts its pull. The posterior cricoarytenoid muscles separate the arytenoids with a rocking motion, and the interarytenoids draw them together again with a rocking and upward gliding movement so that the apexes meet. The lateral cricoarytenoid muscles do this, rocking and gliding. The gliding movement may have a rotating component around the upper or lower corners of the cricoid facet. We notice that the muscular processes are drawn forward and the vocal processes contact each other. When both the laterals and the interarytenoids contract, there is firm contact between the arytenoid cartilages like this. These movements will become more meaningful when we see the vocal folds in place. For this, we need a thyroid cartilage. We are now going to apply air to our specimen and observe the vibration of the vocal folds. It will be necessary to remove the horns of the thyroid to avoid interference with our thread. There is no longitudinal tension, so the vocal folds are loose and thick, and the sound will be that of chest voice. The glottis opens by contraction of the posterior cricoarytenoid muscles. Now the posterior cricoarytenoid muscles relax. Listen to the tone when both the interarytenoid muscles and the lateral cricoarytenoid muscles contract. Let us keep in mind the thickness of the vocal folds. We have been observing their behavior when they are like this. But now, let us apply longitudinal tension. The vocal folds become thin and tense. The sound they will produce is a falsetto tone. At large degrees of longitudinal tension, we can expect small amplitude of movement. It is difficult to move the vocal ligaments away from the midline. Let us apply adequate medial compression and air and observe the vibration under normal light.
So this was done 50 years ago. And the entire laryngeal framework surgery, type 1, type 2, type 3, and type 4, is based on this. So we know type 1 is bringing the vocal cord together. This is in patients with glottic incompetence. Type 2 is separating the vocal cord, and this is in patients with adductor spasmodic dysphonia. Type 3 is for relaxing the vocal cord, and this is for voice deepening. And type 4 is increasing the tension on the vocal cord, and this is for patients that want to raise their pitch. This is your take-home message for this talk for today. And the remaining, I'm just going to share my experience, and I hope that you'll be able to learn something from this today and then from the dissection tomorrow and the live surgery that we're going to be showing next week. Mofoto Ifishiki, he was 84 when he was doing this surgery. So I operated with this guy at the age of 84 with a very steady hand in Kyoto. Right, treatment options. What do we have to offer these patients? Voice therapy should always be an option. There is so much that speech therapists can do with these patients, even educating them of their voice. And sometimes some patients may not have a severe disability with their voice, so a simple voice therapy may help them. We've had a talk about injection, and we're going to talk about thyroplasty now. We've already heard about reinnervation. There is a laryngeal pacer research going on right now by the German group and the Austrian group. The first cohort of the research they did about close to 10 years ago was partially successful, but they had to stop because the cable that was inserted into the PCA was breaking off. But the research is back again. So really, with Ishiki Thyroplasty type 1, the key is to medialize the vocal cord. And in order to medialize the vocal cord, you need to find the appropriate level of the vocal cord. The mistake that people do at the cost of the revision surgery in thyroplasty is because people have not located the right level of the vocal cord. And commonly, people medialize more superior. It is very rare to medialize too inferior, because if you go too inferior, you're going to end up in the subglottis. So the reason why people medialize too superior is because the window is measured too high. And in such cases, you're going to medialize the false cord, and the voice is going to be too tight. So this is one big mistake that people make. So the measurement, the level, is the key to success. Number 2, anterior medialization. If you medialize the vocal cord too anterior, you pinch the anterior commissure, and the voice is going to sound very tight like that. And this is why people with spasmodic dysphonia, the tension is at the anterior commissure. And when you do type 2 thyroplasty, by just separating the anterior commissure by a few millimeters, the voice improves, and we're going to see later. So, to make it simplistic, to measure the level of the vocal cord, you identify the thyroid cartilage upper level, the lower level. The midpoint of the thyroid cartilage is where the level of the vocal cord is. So that's the first step. Now, how far posteriorly does the window start? In female, usually about 5 millimeter. In male, about 8 millimeter. So you go further back, because remember, it's the posterior gap that is causing most problems. And the height of the window in male, 6, and then the length, 12. In female is 5 by 10. This is in cases whereby you don't have the voice implant. If you use silicone implant, I don't know what you use mostly in your country, but every country they have access. And thankfully, we have the voice implant now, which is maybe one of the few implants that are licensed to use in the larynx. But this is just the basic, the real technique that Ishiki described using the silicone implant. And we're going to see a video of one of my patients who was using the silicone implant. So what implant materials do we have available? We have the silicone block, which is very cheap. It's not different from the silicone that you use for curving, so maybe use it for orthoplasty. There's a Montgomery implant, and then there's a voice implant, there's titanium plate, Gore-Tex, Palmocol, and so many other things that people use across the world. So this was a patient that was referred to me. This patient had thyroidectomy and developed vocal cord paralysis on the right side. The key to success is to do this operation under local anesthetic. I heard people are doing it under general anesthetic. I don't know why, but individuals have a reason why they do that under general anesthetic in some countries because of reimbursement. I know in Germany they do that under general anesthetic because if you do it under local, you don't get paid much, so you put the patient to sleep and then you get reimbursement. Some people do it under GA because they're afraid they're going to hurt the patient. Some people do it under GA because they've not seen it done under local and they've not learned it. But I have never done this under GA. All my cases I've done it under local anesthetic. In about 1%, the anesthetist gives a tiny bit of sedation when I'm drilling the window, but during the titration, when I'm putting the implant, no sedation, nothing. Because how will you know that the patient's voice has improved? If you don't do that, your revision rate is going to be very high. If you use the voice implant, you can do it under GA, but the rate of reinflation or deflation is very high. I think the voice implant, okay, it's good for general anesthetic because you know you can adjust it. But if you use other materials and you put it under GA, and if it doesn't work, you have to take the patient back to theater again. So this is the one advantage with the voice implant. So to make it successful under local anesthetic, you give adequate local anesthetic. How do you do that? I used bupivacaine, 0.25% bupivacaine with adrenaline 1 in 200,000. Why bupivacaine? Because bupivacaine has a low cardiac toxicity and it's long-acting as well. So you have over 2 hours for the local anesthetic. I use up to 20 mils. I put 5 mils on each thyroid lamella. That's 10 mils gone. Another 10 mils across the line of the incision. That's 20 mils. And also have a spare 10 to 20 mils of xylocaine 1%, because sometimes when you're inside the neck, there are some areas in the neck that perhaps the bupivacaine hasn't reached, and if the patient feels any discomfort, you can top it up. So you take it step by step, slowly, and you find that actually you finish your operation with patient not requiring any sedation or any general anesthetic. And I'm hoping, I'm talking with the organizers now if we can do the case on Monday on the local anesthetic. So I'm just gonna play, sit and relax and enjoy the video. Again, with this patient, I make about 5 centimeter incision, go through the skin, subcutaneous tissue, platysma. I don't cut the strap muscle and separate it, expose the thyroid lamella on that side completely. You measure the window. How you measure the window, you measure the upper part of the thyroid cartilage, the lower part of the thyroid cartilage. The midpoint is where the level of the vocal cord, and you go posteriorly by about 5 millimeter. That's the start of your window. For female, it's 5 by 10 millimeter, and for male, it's 12 by 6. This is if you're going to be using silicone implant. But if you're going to be using voice implant, I'll show it to you later. So that's the thyroid notch, cracked with cartilage, the incision there, going through the skin, and the fatty tissue there. I normally put like a stay suture on the thyroid notch so that I will retract it, and my assistant can retract the thyroid cartilage to the opposite side, and then I can see it clearly there. So you can see the thyroid notch there, the inferior border. So I've measured the length. It's about 14 millimeter. So halfway is 7 millimeter. So I know if I mark the window, in this case it's a female patient, 5 millimeter, I'll be left with 2 millimeter inferior rim of the window. So laterally by about 5 millimeter. For a male, I'll make it longer. And this is the start of your window. If the window is too anteriorly, you're going to pinch the anterior commissure. So I've got 10 by 5 millimeter window. That. In a soft cartilage, you can use knife, but patient over age of 30, you may have to use drill. I use 1 millimeter Fisher bar drill to take the window out. And this is just the window sizer, and this is a silicone implant that I use to cut it. So if you use silicone implant, or if you have access to silicone implant, this is how you cut it, in a wedge shape, almost like the Montgomery implant. So the anterior part of the implant is shallow and the posterior part is deeper because that is the bit that is going to medialize the posterior gap. So the groove here is so that it will fit into the thyroid cartilage, and I've never encountered any extrusion because it sits snugly into the thyroid window. So you can see the anterior bit there and then the posterior bit there. And this is 1 millimeter Fisher bar. You make 4 corners drill, and then you make like a post office stamp perforations, and then you connect the holes together, and then you remove the cartilage. If you cut through the inner perichondrium, don't worry, it's not the end of the world. As long as you don't go into the vocal ligament, you can put adrenaline, 1 in 1,000, on the neuropathy to reduce the bleeding. And this is the thyroid window coming out. Gently. Again, this is all under local anesthetic. This patient wasn't feeling the pain. And there's the implant going in. So that's the silicone implant. This was a patient of mine that
A young brat named Arthur, who could never make up his mind. Whenever his friends asked him, he would like to go out with them.
She had congenital vocal cord paralysis.
8, 9.
As you can see, she has a very wide posterior glottic gap, and a very thin vocal cord. So this is just to show you what the Montgomery implant looks like. Very much similar to the silicone implant that I used.
Whenever his friends asked him if he would like to go out with them, he would only answer, "I don't know." 3, 4, 5,
So this is again after the
1,
surgery,
2,
and this was before the
3,
surgery.
4, 7, 8, 9, 10.
Can you say E? You say E? You say E? You get a nice one like an opera. Yeah. So now thyroplasty type 1 using the voice implant, and I think this is gonna be, I'm hoping it's gonna be a game changer. This is still new. It's just over 5 years since it's been available in the market. And as you can see here, it has a silicone port, and it has a titanium base, and this bit is the posterior, and this is the anterior. The key point on this implant are this chamber here that you can inflate depending on the size. If it is a male size, the maximum you can insert is 0.3 millimeter. And this bit here is posteriorly, and this is the anterior wedge. And there's a port here that you can insert the saline intraoperatively or later in the clinic. These are just some instruments that you can use to measure the size and then the window as well. So there are lots of equipment on the tray. Lots. I still can't remember the names of this equipment. So what I do, I'll ask my nurse to put it very close to me, and I just pick what I want. So you can see here on the X, there's XS. So on the XS, you have 2 sizes, and then on the S, you have 2 sizes, and then on the male, the medium, and then the large, you have 2 sizes. So this is for male size. So you have 8 sizes for a male and 8 sizes for a female. However, the company makes it such that you only pay on what you've inserted into a patient. So after you finish all your measurement, you choose which one that fits in, and that's what you pay for. But normally they will supply you with 8 implants per patient, which you're gonna need just 1. So you have to tell them whether it is male or female patient. And these are the instruments. You can see from here, it's like a freer here. And this is for measuring the start of the window and the level of the window, marking the window, some screws here, and then the window size are here. And let's see how you apply them. So this is just an animation I borrowed from the company. I'm just gonna see if we can play that. So just to understand the principles of the medialization with the voice implant. So in this case, you can see obviously the left side that is not working. Nice, beautiful pictures, but you will find out in the cadaver, on the real life surgery, that there is blood in it. It's not like the picture here. And this is looking at the size of the window. And then the level of the window, you do that. And that tells you that the vocal cord is at this level. And then the start of the window, you have a separate equipment for that as well. And then you mark where the window is gonna be. Sometimes you may need to drill a small hole just to confirm the level of the window. And this will mark where you're gonna drill the hole there. And this is the window. And this is the window sizer, implant sizer. Then you can put your implant in. Sounds easy, isn't it? And the implant goes in. And this is the saline going in. So you can see it here, inflating that. So, again, on the picture, the first thing you do is to find the anterior part of the thyroid cartilage. It's called M1. You find the posterior border of the thyroid cartilage. It's called M2. This is where the patient may have pain if you're doing it under local anesthetic. So I normally top it up with lidocaine. So once you do that, you use this ruler to measure whether you're going to need an extra small implant or medium implant or large implant. So when you put the back end of the ruler at the posterior thyroid cartilage lamina, and then the front part of it, it tells you which implant to use. So in this case, it's going to be medium. And then you find the inferior thyroid tubercle. It's not easy to find it. In some patients, it may be flat. But you find point A and B in front of the tubercle, and then you use this L shape to mark the level of the window. And then the start of the window, and then you drill it. So let's look at a real life situation now. This was a patient I did 2 weeks ago. So I have the pre, peri, and post-op video here. It's a patient with lung cancer. He has completed his treatment, and there was a good prognosis. If this patient were to be palliative, then I would probably suggest the patient to have injection medialization. And this patient, again, he needs his voice for his career. He's a DJ, and his work has completely stopped. He does radio program, and he couldn't do any of that because of this. So as I've said earlier on, you prep the patient in the supine position, head tilt slightly 30 degrees to reduce any venous engorgement in the head. You mark the incision line about 5 centimeters ipsilateral on the side of the incision. I go slightly across the midline to the other side so that I can see the entire front of the thyroid cartilage. I use bupivacaine 0.25% with adrenaline 1 in 200,000. It is important to use the adrenaline because it reduces bleeding and also it prolongs the half-life of the bupivacaine. And then the lidocaine for the top-up of injection. Count 1 to 5 for me. 1, 2, 3, 4, 5. Can you say the days of the week for me?
Monday, Tuesday, Wednesday, Thursday.
So that's a local anesthetic going into each thyroid lamella and into the incision site. That's the first incision, platysma, strap muscle separated, stitch holder to retract the thyroid notch, and then marking the level of the vocal cord, and then sizing the implant size. This case is large size, you can see there. And then marking point A and B. And with that, we're going to find the level of the thyroid cartilage using the L-shaped implant there. You can see that. And that gives us how high the window is going to be. And we'll measure from the anterior where the window is going to start. You can see that for a large implant, the window starts there. And this is to mark the entire window. And then I use drill 1 millimeter to mark the corners and the multiple perforations, holes, and then get the cartilage out. Gently peel it off the inner perichondrium, put some neuropathies to stop any bleeding, check that the window is large enough. If it's not, I use diamond burr to just polish any irregularity there. And it goes easily. Now the implant sizer, and then check the implant is not leaky. You put the implant in there. This bit can be very fiddly sometimes. It goes in with a bit of persuasion. I normally inject while I'm looking from inside as well, so the light went dark because I had nasal endoscope inside the patient just to see the degree of medialization. But you know if it works when the patient speaks and the voice is clear on the operating table, not later on when they go home already. This is just tightening the screw there. Then checking the patient's voice at the same time. You can see the patient is moving his chin because he was talking to me. He's not crying for pain. So why are you doing this under general anesthetic? I don't know. And this is it all done. This is just the next morning.
4, 5, 3, 4,
This is before.
5, 6, 7, 8, 9, 10.
You can see the days of the week for me.
Monday, Tuesday,
So
Wednesday.
the voice is still a bit gravelly because of the bruising and the vocal cord. And this is another case, again, voice implant, pre-recording. So this is a big gap. So you can use it in small gap or big gaps. In the surgery, I think we're just going to go over this because we've already seen the surgery. This is 1 or 4 weeks post-op.
Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday.
And this 4 week post-op, the bruising has settled down. And this is 6 months post-op. So you remember earlier there was, the maximum for the shift time was like 4 seconds. But now you went up to 10 seconds.
1, 2, 3, 4, 5. Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday.
This is another one again, pre-op. This is post-op.
1, 2, 3, 4, 5.
Again,
2, 3,
pre-op.
4, 5.
So you can see in this patient the voice is not too bad actually, but look at the post-op.
2, 3, 4, 5.
She's got almost normal voice now. Sometimes there could be problems with thyroplasty. This was a patient had the silicone implant, and then the patient went back on the anticoagulant the next morning and developed hematoma. So I had to give antibiotics and steroids. That settled down without having to take the patient back to theater. So the tips for thyroplasty is to make it low. You can't go any low. The low, the better. So if you finish the window and you find that you're more than 3 millimeter, then the window is too high. So you need to keep the window, the lower rim of the window, 1 or 2 millimeter. If it is too thin, it may fracture. So your gauge is about 1 or 2 millimeter. Again, avoid too much trauma to the inner perichondrium because you may have hematoma, and that can medialize the vocal cord before you even put the implant. And do not medialize too much anteriorly. Stay parallel to inferior border of the thyroid lamina. I've seen cases whereby people put the implant and they think that the oblique line is the inferior border, so the back end of the implant is in the false chord, and that does not work. But most importantly, try and do it under local anesthetic. It does work. You find that you get the maximum, the best outcome for your patient. So type 2 thyroplasty, this is going to be quick now, and it is indicated for adductor spasmodic dysphonia. The whole idea is to separate the anterior commissure with each of the vocal cord on the thyroid lamina, and that way you create a gap and you stop the squeezing on the vocal cord. This is what it looks like. You use titanium bridge. Currently it's only available in Japan. So the patients that I have here, my patients, I had to go to Japan with them and operated with Professor Ishiki and his team in 2015 and 2016. That was when I went there. So you can see how you make the laryngeal fissure there, and then the implant goes in there. So you need like a caliper to measure it. So this is the anterior commissure before, and this is what it looks like after. Yeah. So this was one of the patients, a patient of mine that wasn't responding much with Botox. Well, she required like 4 units of Botox every 2 to 3 months. It wasn't sufficient. And I did CO2 laser pharoaryngenoid myoneurectomy, which wasn't successful, even with revision. So in the end, I went to Japan with her and we did the surgery. And this is the voice before and after. Read for me.
1, 2, 3. There was once a young painter who would ever say, there was once a young
This is the voice after.
He would never take the trouble to make up his mind. 1, 2, 3.
And then relaxation thyroplasty, when do you need it? You need it in pubophonia, or if there is anybody want to change their voice from female to male voice, and this is how you do that. There are different techniques that I describe, and I've recently described my technique, which I'm going to share with you. So this is Ishiki's technique. Essentially, you make a vertical incision and take strips of cartilage on each side of thyroid lamina. This can be a bit messy if you're not too careful, and the voice can be too deep, and you have to stitch it back again with Prolin. There is a diamond cartilage incision described by the Turkish guys, and I've recently described this technique that I use rectangular size cartilage incision. So I'm going to show you the Ishiki technique first, and then my technique. So this was a patient of mine with some degree of pipophonia. It's not too bad. Now when you hear the voice, you will say, well, what is he talking about? But this guy is a school teacher. He feels like his voice, he cannot command his class, and he goes very high pitch. And we know deep voice, people interpret it as commanding commands. We know some of our leaders, the previous Prime Minister in the UK, Margaret Thatcher, she had to lower her voice, she had like voice training. Angela Merkel as well, the voice she has now is not hers, she has to do some training to deepen the voice. In the UK, when Margaret Thatcher deepened her voice, she was able to control the houses of the parliament. Even when she died, she's still controlling some of them.
5 for me, please.
Loud.
Yeah.
1, 2, 3, 4, 5.
Can you say E?
E.
Now some of you will say, well, what is he talking about here?
E.
But let's see the end.
Can you read the first?
So don't rush into judgment yet.
There was once a young rat named Arthur who would never take the trouble to make up his mind.
Again, you have to do this surgery under local anesthetic.
Like to go out with them, he would only answer, I don't know. He wouldn't say, yeah.
So this is the surgery. So this is what I removed on both sides. Again, this is even more invasive than a thyroplasty type 1, and did it under local anesthetic. So I'm doing it because I have to check to see whether he likes his new voice. There's no way you can do this under general anesthetic. Because how would you know the level of condition is? See, he's relaxed, he's not crying for pain. Maybe he is, he's not telling me, I don't know.
Count 1 to 5 for me.
1, 2, 3, 4, 5.
Count 1 to 5.
1, 2, 3, 4,
So
5.
I'm trying to reduce it
1 to
more,
5.
1,
but
2,
it's too deep
3,
and he didn't
4,
like that.
5.
Very loud.
That's the 1, 2, 3,
Let's check in to see
4,
which of his
5.
voice is better for
Again, count 1 to 5.
1, 2, 3, 4, 5.
Count 1 to 5.
1, 2, 3, 4, 5.
So this is number 1. Count 1 to 5.
1, 2, 3, 4, 5.
And this is number 2. Count 1 to 5.
1, 2, 3, 4, 5.
Which one do you prefer, number 1 or number 2?
Number 2.
Number 2.
He wants number 2. Oh, you like number 1, okay? Actually, I had my speech therapy in the theater as well, and some of the ladies said to him to go for number 1. I said, no, number 2 is better. And he was right, he went for number 2, and you're going to hear it later. So normally and how you're going to measure it, you have to use the ruler, put it in to see how, with that level, you determine how much you excise.
1, 2, 3.
So usually about 3 millimeter
5.
maximum, that's what you need. In some cases 1 millimeter or 2 millimeter of the thyroid cartilage, and you use Prolin 3O to stitch there on the top, in the middle, and on the sides as well, because otherwise you're going to have my level of the vocal cord, and that can be a problem later.
1, 2, 3, 4, 5.
Count 1 to 5.
1, 2, 3, 4, 5.
Count 1 to 5.
1, 2, 3.
Yeah, so this is it after now. This is the number 2 that he chose. Let's listen to that.
Count 1 to 5 for me.
1, 2, 3.
There you go. Oh.
There was once a young rat named Arthur who would never take the trouble to make up his mind. Whenever his friends asked him to go out with them,
Do you hear that?
he would only answer, I don't know. He wouldn't say yes, and he wouldn't say no.
Thank you.
What do you think of his mind?
It's a cool
Yeah, he doesn't want to glide off.
original voice. I'm having to relearn my speech, the sound of my speech, my delivery. But overall, I simply could not be more satisfied with what is clearly a radical transformation.
So, This is it. So, and I had another patient who couldn't decide how much he wants to lower his voice. And using the Ishiki technique, he's going to lower too much. And using the Turkish technique is not sufficient enough. So that morning, I said to him, you know, let me go think about it. You go think about it. If you don't want this operation, we'll cancel it. So I went to see another patient, and I just thought about this in my mind. I said, well, I've got to think of something. Got a piece of tissue paper, drew that. I went back to him and said, this is what I'm going to offer you. I've not tried this on anybody. And he came from abroad actually, so he had to make a decision there. Say, I believe this is going to work, and I don't think this can go wrong. And he agreed, and we did that, and this is the measurement that I have. So make an incision of an island of cartilage, and then push that further back, and then check, and we're going to see what it looks like. So this is beforehand.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently.
So again, this is the measurement, as you can see over there. It's about 10 millimeter either side, and then you find the mid portion. Depending on the height of the thyrocartilage, this rectangular window should be right in the middle. And the anterior commissure is there. So when you make a cut there, you push the thyrocartilage back and it relaxes the vocal cord. Again, under local anesthetic. So it's a midline incision. Separate the thyroid, the strap muscles. You don't have to see the whole of the thyroid lamina, just the front part of it. You can see the measurement there that I've used. Use a caliper to find the level of the anterior commissure. You go halfway between the top of the thyroid cartilage and then the level of the vocal cord. Okay, 10 millimeter laterally. So roughly about 10 millimeter either side of the midline, and then 5 millimeters above and below. And then drill the thyroid window, and then free the inner pedicondyle gently, and then push the cartilage back, and then check the patient's voice. You don't need to put any stitch there because the inner pedicondyle is very tough. Say E. And this is the voice. Intraoperatively, I was
And
checking.
1 to 5?
1, 2. Nobody but you.
This is the voice you want. He wanted the voice of Barry White, he says so.
We've got it together, baby.
The rainbow passage. When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon. There is, according to legend, a boiling pot of gold at one end. People look, but no one ever finds it. When a man looks for something beyond his reach, his friends say he is looking for the pot of gold at the end of the rainbow.
He said, so you can see, you can change the pitch, yeah. He can sing. Did you hear Barry White singing earlier on? You don't need a high pitch to sing, yeah? So it is very important for some people. The voice, your voice is who you are. And sometimes we take it for granted. And this is why there are things that we can offer these patients. So the tip for these patients are just be careful, because some of these patients, they think their success in life depending on their voice. And you may do this surgery and find that actually what they're looking for in life, it didn't work. So it may be worth trying Botox injection into the cricothyroid muscle, and then they feel, because that is going to deepen the voice first, and then they will know what it feels like. And if they feel like it's not what they want, then they will leave you alone. Sometimes some of these patients might have sulcus, and the voice may be very high pitched because of that. And when you do this relaxation therapy, the patient may not improve with that as well. So it's very important to counsel the patients and then the expectation as well, to manage the expectation well. So the last one is Ishiki pharoplasty type 4. Again, this is for rising the pitch. And there are two techniques now, the pharoplasty type 4 or the glottoplasty. And I think the glottoplasty surpasses the thyroplasty type 4. I don't know why, but my feeling is because the glottoplasty is done under general anesthetic. People find it easier to do that. With the pharoplasty, sometimes with a very firm cartilage, it's difficult to approximate it as well. So type 4 was described by Ishiki, and then the glottoplasty by Wendler. Wendler, I think he's like 98 years now, he's still in Berlin. But as we know, Ishiki sadly passed away 2022. So let's look at the Ishiki pharoplasty type 4. And the whole idea is to approximate the cricoid cartilage. For both type 3 and type 4, I actually check the patients in the clinic before I offer them the surgery. And if you don't mind, we could probably do a quick demonstration here. So for the type 3, have we got a male here? No, for the type 3, we need a female that wants to drop the voice, or a male. What's your voice like? Come over here then, yeah? So assuming if this patient wants to increase the pitch, yeah, so I test in the clinic first. So by putting my finger under the, I'm gonna come over here, maybe you can see this finger. So I put my finger under the cricoid cartilage and then pull it up to approximate it. It may hurt a bit, but I'll try not to squeeze it too much. So I want you to, before I put the pressure, I want you to count 1 to 5 for me. 1, 2, 3, 4, 5. He's afraid. So it's not going to be permanent, yeah? Right. Count 1 to 5. 1, 2. Why are you talking with high pitch voice? There we go. And again, 1, 2, 3. 1, 2, 3, 4, 5, 6. So, for cricothyroid approximation, this is how you check, and the patient will hear the voice. And they say, okay, do you like that? If they say yes, yeah, we'll carry on with the surgery. So now we're going to deepen the voice. So, can I have a lady that will allow me to touch her neck? Okay? You're going to sound like a tiger now. So come over here. So you can stand here. So, can you count 1 to 5 for me?
1, 2, 3, 4, 5.
Okay. She's afraid now, her voice is going to go. Count 1 to 5.
1, 2, 3.
Count 1 to 5.
1, 2, 3, 4, 5.
Yes, final. Count 1 to 5.
1, 2, 3, 4, 5.
Count 1 to 5.
1, 2, 3, 4, 5.
Count 1 to 5.
1, 2, 3, 4, 5.
Again.
1, 2, 3, 4, 5.
So you try like that, and when you press, it's more difficult because it is hurting a bit.
Oh, no.
You know, should we do a bit more then?
Yeah. But don't break it.
Okay. Yeah. If you're breaking your voice, it's going to be permanently deep then. Yeah. And 1 to 5.
1, 2, 3, 4, 5.
1 to 5.
1, 2, 3, 4, 5.
It's very difficult to get that voice down. And actually, there are patients that will be a bit tricky like that. So when you press it down, thank you very much for that. The voice can go down, and the patient can hear it. And then if they like it, then you proceed with that. Push it backward, yeah. So again, this is the cricothyroid approximation. And this is a patient, one of my patients that wants the voice raised up. And let's play the voice beforehand. You count 1 to 5 for me.
1, 2, 3, 4, 5.
Can you do that now?
You can say E for as long as you can, and loud. Count 1 to 5.
Sorry. 1, 2, 3, 4, 5.
Right, can you count 1 to 5 now?
1, 2, 3, 4.
Say E. Count 1 to 5.
1, 2, 3, 4, 5.
Again.
1, 2, 3, 4, 5.
So which one do you prefer now? You can tell you how high you want your voice pitch to be. So try 1 to 5.
1, 2, 3, 4, 5.
How is this?
Does it sound alright to everyone else?
Is that order for everybody else? He's
Right.
asking.
1, 2, 3, 4, 5.
So again, it's very important to do this under local anesthetic. So if you're going to do
So let's
thyroid
try again.
please
1,
learn how to do it
2,
under
3,
local.
4, 5.
Again.
1, 2, 3, 4.
And this is the voice 18 months after.
So I count 1 to 5 for you, please.
1, 2, 3, 4, 5.
Can you read that first paragraph for me, please?
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow.
And this is a patient over 2 years.
Can you count 1 to 5 for me, please?
1, 2, 3, 4, 5.
Can you say E? Can you read that for me now?
Okay. The story of Arthur the rat. There was once a young rat named Arthur who would never take.
Yeah. So also, there are, this is another patient pre-op.
So can you count 1 to 5 for me, please?
1, 2, 3, 4, 5.
Can you say E?
And this is post-op.
Count 1 to 5 for me, please.
1, 2, 3, 4, 5.
Can you say Monday to Friday?
Monday, Tuesday, Wednesday, Thursday, Friday.
Can you read the first Friday?
Again, this patient had a total thyroidectomy, and her voice went quite deep. And I think it's one of the commonest complications from thyroidectomy. And these patients, this thyroid surgeon will tell them the vocal cord is moving fine. Most people, if it's a male, it's not a problem because the voice will be deep. Most men are begging for a deeper voice like that. But if it's a female, it's going to be a problem. This patient of mine, she's a female, she had total thyroidectomy, and her voice quite deep. She can't even talk on the phone because when she answered the phone, people will say, well, I want to talk to your wife. Why are you, she is the husband. And also if somebody is a professional voice user, they've had it. If he's a news broadcaster or a school teacher or a lecturer, you need your voice to check and the tone, otherwise it's going to be too monotonous. And these patients are going to need your help to improve with that. So this is the patient. The voice before.
1, 2, 3, 4, 5. Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday.
And this is the surgery.
Can you say E?
E.
Again E.
E.
You can say E.
E.
And 1 to 3.
1, 2, 3.
And this is after, at the end of the day.
1, 2, 3.
This is her original voice that she used to have before the thyroid surgery.
1, 2, 3, 4, 5.
You say E.
E.
When she came back post-op, the fundamental frequency went up to 243, and before the surgery it was like around 160. So I think this is the last slide now.
Tuesday, Wednesday, Thursday, Friday, Saturday.
So you can see there's so much you can offer these patients with this technique, and thanks to Professor Ishiki. And there are so many ways you can learn this. You can learn that by going to courses, you can visit centers, and I think a lot of you have been to my course in Manchester, and now it's in London, and I think quite a few from here will be meeting up in April, and you can visit centers as well, and that way you'll be able to give comprehensive service to your patients. So all the type of plastic, type 1, 2, 3, 4, you can do them, as you've seen over here. Thank you very much.